For our first episode of CVAM Chats, we have a very special treat for you all. We have Dr. Ambrose Panico, who is our electrophysiologist. Dr. Panico, welcome to the program.
Thanks for having me.
Can you tell us a little bit about yourself and then also why you chose to become a cardiologist, specifically an electrophysiologist?
Sure, I'd be happy to. So I'm born and raised in the Chicago suburbs and came here about 2 years ago to join the practice. Been super excited to be here. I decided to become a cardiologist largely based on kind of the experience I had growing up with my grandfather, who had a lot of cardiac issues. And actually, it's an interesting story. That's how I decided to become an electrophysiologist as well. My grandfather was actually supposed to be one of the first patients in the original ICD trials. And unfortunately, he didn't make it to those trials, but that kind of sparked my interest and intrigue into going into the field of electrophysiology.
That's a terrific story, and that's a great motivation. So, tell us a little bit about which of our patients should actually be seeing an electrophysiologist.
Sure, quite a few actually. An electrophysiologist deals primarily with abnormal heart rhythms, which we can see in all different forms. They can be fast heart rhythms, they can be slow heart rhythms. It can even be just a predisposition to an abnormal or life-threatening heart rhythm because of some other coexisting cardiac comorbidities.
So, Dr. Panico, can you tell us a little bit about what atrial fibrillation is and what causes this particular problem?
Sure. Atrial fibrillation is an extremely common heart rhythm disorder in this country and worldwide. And that's in part, or large part, due to the company that atrial fibrillation keeps. A lot of our cardiac patients have a number of comorbidities that do predispose to atrial fibrillation. But unfortunately, the number one predisposition to atrial fibrillation is just age itself. So it's something we see exceedingly more frequently as our population, continues to live longer and healthier lives. Atrial fibrillation itself is an abnormal heart rhythm generating from the top chambers of the heart. It's essentially electrical chaos or disarray. The top chamber or the atrium can be going anywhere from 300 to 600 beats a minute. And the bottom chamber, the ventricle, is just trying to keep up and kind of hold its own. When we talk about management of atrial fibrillation, there's a number of issues that need to be addressed. And in most cases, our primary issue that we want to make sure is adequately addressed is the issue of stroke predisposition. And so once we see a patient who has atrial fibrillation, we like to discern their individualized stroke risk to help determine what anticoagulation that they should be on, and if it's appropriate, and if so, for how long they need to be anticoagulated.
Can you tell us a little bit about your approach to treating atrial fibrillation?
Absolutely. So primarily when we meet a new patient in the electrophysiology clinic with atrial fibrillation, our first thing we want to determine is, are they symptomatic? And if so, to what extent? Because that really helps frame what management options are most appropriate for that patient.
Dr. Panico, what is an ablation and who is a good candidate for this particular procedure?
Sure. An ablation is a procedure where we try to deal with the arrhythmia without having to submit somebody to long-term medical therapy. And what we do in an ablation is bring them into the electrophysiology lab, and they generally get put under anesthesia. Once they're asleep, we insert some catheters through the veins in their groin, and that allows us to get all of the equipment we need up to the heart to do the procedure effectively and safely. We use the catheters not only to diagnostically create a 3D map of the inside of the heart as well as the electrical circuitry of the heart, but to then help us guide our targeted ablation strategy for whatever the arrhythmia, specifically in this case, atrial fibrillation, that we would be dealing with. As far as candidates for an atrial fibrillation ablation, to be honest, again, it's a very individualized strategy. Most patients, as long as they are active and functionally able to recover from a procedure, will do better with an ablation strategy. And it's a conversation I have with almost all the patients I see for atrial fibrillation, and we kind of just decide together what the best approach for them would be. And quite frankly, most of the time they decide that they'd like to avoid long-term medical therapy and end up moving forward with a catheter ablation.
So Dr. Panico, shifting gears a little bit, can you tell me the difference between a pacemaker and a defibrillator? Because that's one of the most common questions I get asked from
Absolutely.
patients.
So both are implanted cardiac devices, and both serve, while similar, also different functions. A pacemaker primarily is implanted just to take care of a slow heart rate or slow heart rhythm, and it serves basically as your backup. When your heart doesn't create that electrical signal on its own, the pacemaker kicks in. Now, a defibrillator has that same capabilities, but a defibrillator is a device that we implant in somebody who's at risk for life-threatening cardiac arrhythmias, and a defibrillator will then shock or try to pace the patient out of that life-threatening arrhythmia when appropriate.
So, Dr. Panico, a lot of the patients I'm seeing in our post-COVID era are these so-called long haulers who have a lot of cardiac issues, whether it be shortness of breath or palpitations or high heart rate. Can you tell us a little bit about this post-COVID long hauler phenomenon from an electrophysiology standpoint?
Sure. So we are seeing a lot of that, and it shares a lot of clinical similarity with what's called inappropriate sinus tachycardia or the postural orthostatic tachycardia syndrome, all of which fall under the spectrum of autonomic dysfunction. And for whatever reason, we've seen this with other viruses historically, but with COVID, it's been just rampant. People have a varying degree of symptoms. Could be anything from feeling palpitations, heart racing, lightheaded, short of breath, fatigue, no energy. They can be positional, they can be all the time. We're seeing just about any type of symptom with it.
So treatment for these patients has been challenging from a provider standpoint, and patients are frustrated because it's been challenging from their standpoint. Are there any novel treatment options for them now?
Yeah, so there are a lot of options out there, and it's from things just as simple as lifestyle modification, adequate hydration, making sure they're getting adequate, electrolytes and sodium in the diet, compression stockings. All of those things are kind of the mainstay for autonomic dysfunction. We do have some pharmacotherapy that can be useful as well. And in a lot of these patients that we're seeing, we have started to approach kind of some more cutting edge ablation strategies that we're able to use.
We see a lot of post-COVID patients, so-called long haulers, who have these cardiac symptoms of palpitation, shortness of breath, and certainly it's frustrating for them, and it's also frustrating for us because our treatment options have been limited. What symptoms should these patients be looking for, and who should be referred to an electrophysiologist?
Sure. A lot of the symptoms we see overlap with what we see in autonomic dysfunction, like inappropriate sinus tachycardia, the postural orthostatic tachycardia syndrome, and unfortunately those symptoms vary so dramatically between patients. Primarily lightheadedness, dizziness, heart racing, skipping beats, shortness of breath with activity, fatigue, low energy, all very vague symptoms, and that's likely why we've seen such an overlap with COVID. As far as who needs to see an electrophysiologist, I think it's anybody who's failed to respond to conservative management with, fluid resuscitation, adequate electrolyte replacement, sodium in the diet, compression stockings, and things of that nature. Because at that point, we have to start thinking about other options, including pharmacotherapy, as well as some procedural-based options that may be available for specific patients.
So this is now my favorite part of the interview. This is what I like to call rapid fire at CVAM chats. You ready?
I'm ready.
Best slice of pizza you've ever had?
Ooh, that's a very difficult question. First thing I'd like to clarify is that people from Chicago do not like deep dish pizza. That's a tourist pie. So any of the better thin crust pizzas you can find around the city, mostly in the suburbs, to be honest. Vito and Nick's, always fantastic. I grew up on Aurelio's. But the best slice for my money is a little hole in the wall called Louisa's. Fresh sausage and fresh garlic, to die for.
I'll have to check it out. How about dream vacation location?
Ooh, that's another tough one. That's going to take me no time to answer. Bora Bora, no kids.
Sounds amazing. And on a more serious note, tell us one question that a patient who comes to see an electrophysiologist should ask before they leave that appointment.
That's a tough one to answer, and I think it really depends on what the substance of the appointment was. But I think that the biggest question every patient should ask their electrophysiologist is, do you think this is what's best for me? Because in medicine we have so many options to treat everybody, and there's no one-size-fits-all approach. And when it comes to doing a lot of procedural-based therapies, you want to make sure that you have the best fit for that individual patient.
Dr. Panico, thank you so much for joining us on our first episode of CVAM Chats. We look forward to seeing everyone next time.